Okay. Stream started. Assalamu alaikum wa rahmatullahi wa barakatuh. Sorry for the technical delays. Thank you for bearing with us, Brother Adnan. We have Brother Adnan Ahmed today with us. He's a Director of Public Health at Michigan, University of Michigan Health Network, and has a plethora of experience in the world of public health. He's going to teach us about bioinformatics. Brother Adnan Ahmed has an MBA from University of Michigan as well, and Masters of Public Health. So we have a very talented, experienced brother with us today. Inshallah, without further ado, Brother Adnan Ahmed, Bioinformatics.
Assalamu alaikum everyone. Jazakallah khair, Brother Mahmoud. So I first want to say that, since I've been seeing this TechMeetup and happening for about a few months now, I always felt that this was a great topic to kind of bring up just because it's kind of near and dear to me. Been a part of this community, mashallah, for our family's been here for 40 plus years. So like, alhamdulillah, seeing this from the ground up and having an opportunity to do this is a blessing in itself, and may Allah subhanahu wa ta'ala continue to bless us in this gathering here, inshallah. So before I begin, I also want to thank Brother Mahmoud for allowing me to not be able to put my kids to sleep today. So alhamdulillah, that's one responsibility a little bit away. Alhamdulillah. But anyway, so I will want to ask, how many of you have gotten a phone alert right after you've gone to do lab work? That comes in with your lab results. If you want to raise a hand, you get your lab results automatically before your doctor sees it. A lot of you get texts from city health departments when it comes to COVID testing. That's one thing that we saw back in 2020. You also have patient portal access off of your phone. So all this is driven by data, and that is what drives health informatics. So really, to me, today's really kind of pulling the curtain behind the scenes of what makes this such an interesting field. So the technical definition for health informatics, in essence, is really looking at the science of how data is collected, organized, and then shared to make better decisions, right? So there's three elements to this. You have the people element, which is your patients, you have your clinicians, you have your physicians, you have your public health officials, you have your public, community outreach organizations. All of those are considered, essential members of where we get our data from. That data will then come through as a clinical record, as an EHR record. They would be de-identified in some cases and put into a surveillance system, which what we call is our NED system for electronic disease surveillance. And then, we also use that for population health analytics to kind of determine and see how our communities are doing as it relates to, social determinants of health, which I'll get into later. I know it's a term that's kind of not used often, but I'll kind of explain it as we go further into it. And then how do we use technology to really make sense out of this? Because what it is that, you have unstructured data, right? You have all this information coming from multiple sources, coming from multiple things, all coming to you at once. And how do you, make it more informational? How do you make it more user-friendly? So really, that's taking all this information and then trying to make sense out of it. So in the bigger picture of this, you're taking health data to drive better decisions, right? And it's not only better decisions for the patients, but it's for the hospitals, it's for communities at large. And that's what really is the fundamental value of the health informatics, the data-driven health. That's the big picture of why this is important. We take your raw data, then you go ahead and take that raw data that's like a lab result, vitals or a disease report, a patient history, and that feeds into our informatics systems, right? So it's systems that we built to kind of make sense of what this data means on the back end. So that's cleaning it up on the back end, analyzing, modeling, and visualizing what that data could mean. And then from there, then it goes to our health officials, it goes to our executives to make those decisions on, what do we do with this data. And that really kind of builds into better clinical choices. It goes into the better disease detections, and then public health interventions. So, one thing that we, look at is, trying to basically capture essential information before it happens, right? So when we kind of take a look back to 2020, how do we start getting that information, right, from China? It came in as case reports, and then it comes in as 1 or 2 clusters, and then all of a sudden there's an algorithm that really kind of, puts up an alert, says that, this might be a major issue. So then your officials take that information and say, well, what do we have to build or do behind the scenes to prepare? And, from that, then, we had our, response teams. And I do want to give a caveat to this. This is why it's essential to fund public health programs, right? Because if we fund public health programs, we can actually build a better community and a better society. I know that, there's a lot of issues when it comes to, how's my information going to be used? How's my data going to be used? If your data is being used for the greater good and it's being used for the, sole purpose of saving humanity, then that's something that, needs to be considered, right? So to me, when we think about this, we think about, the human being and the community in general as a whole. So to kind of give a little about myself, I'm currently the Director of Operations for the Von Whitelander Women's Hospital and the Fetal Diagnosis and Treatment Center at the University of Michigan. I did my bachelor's in business at U of M Dearborn. I did my MBA at U of M Flint, and then I did my MPH at Emory University. And I came into this field really organically. Like I started off, managing projects. And when you think about project management, you're always thinking at, you're trying to meet deadlines, you're trying to, follow the process, you're trying to meet budgets, you're trying to work with stakeholders. But in some cases, you have to go into the data, you have to go into the information, you have to go see what makes sense. And to me, I had started my, career pathway through healthcare. So, I worked at Blue Cross Blue Shield, and then I moved over into 2013 into nursing informatics at U of M. And at that time, they were implementing a new electronic health record system that was going to be used across the inpatient. And the whole focus was, how do we train 2,700 users within 8 weeks to be able to use a new electronic health system? So in that, you have to be able to prepare, train, get people ready, understand the workflows, understand, how do we make sense of, all these, massive, algorithms that are, paper-based, that are, that you'd have to kind of code in to become a workflow to be able to help clinicians be able to do their jobs. So doing all of that really got me interested in kind of exploring more into this field. So with that, I had the opportunity to go back to Blue Cross, thinking that, it'd be easier, better work-life balance. And to me, what I ended up understanding was that I actually miss this type of work. So hospital operations is what I currently do. But I want to bring up compliance technology for Blue Cross because we were implementing a governance risk compliance solution called MetricStream. And what that did was that you use a out-of-the-box software and you're building, intricate departmental workflows into this software, and then, trying to automate versus what would have been done paper-based or email or things like that. So really working with all these departments at Blue Cross. And then from building those skill sets, was able to go into the Chief Medical Officer office in 2019. And from dealing with projects that had to deal with intricate clinical workflows and how do we operationalize it into our EHR systems, to our COVID response, to then what I currently do now, which is really manage operations within the hospital and our clinical teams. Really getting an understanding in a sense of how do we apply, how do we utilize technology to make people's lives easier. So that's what made me interested in this work. Did you have a question?
Please. So you stopped one thing in 2019, you started another thing. During that transition, you're an essential worker?
No, so I was a senior project manager during my time in nursing informatics. I managed not only the EHR implementation, but also managed the department of nursing informatics.
So somewhere from January to March, we didn't know if there was going to be a shutdown.
Yeah.
And when there was, eventually in March.
Oh, so you're talking about 2020.
Okay. So what skill set was happening at that time in the 2019 to now, 2019 to 2020? What skill set, what habits of mind were you and your colleagues having when everything else was shutting down, but you were not shutting down?
Well, I mean, we knew that we were going to be the last line of defense, right? We were going to be the ones that had to take care of the patients. And actually, the first COVID patient in the state of Michigan was at U of M. It happened on March 13th. So, like, literally, the moment that we were notified that, we have a patient that was, COVID positive being seen here, then we had to, change and shift our complete operations. So that meant mobilizing a regional infection containment unit, which is called the RICU. And then from there, thinking that, this could be a real life possible pandemic, you're building out, a mobile field hospital, which we were planning out over on the track field. And alhamdulillah, we didn't end up using it. But, you had to, build these things along the same time, trying to think about, okay, what is the potential impact in the future? But it's literally we were actually preparing for it starting February, because I remember January, we were, and this was like in a meeting, we were talking, and like it was the chief medical officer at the time, and then a few other colleagues, and we were saying, wow, they're in China, they're building up all these new hospitals in 10 days. Like, that's amazing. And we really weren't thinking that it would be to that, that span. But then, obviously, with the whole process of a disease and how quickly it spreads, we had to be prepared. And then that's where, it's up to our public health officials, it's up to our government officials to take serious of these type of things, right? So then that would help build our responses to be able to handle these situations going forward. Yes?
And how is the surveillance part of this? Like you take the data of the patient.
Yes.
And you feed it to the surveillance system.
Mm-hmm.
For what?
So for tracking purposes, to be able to kind of see if there's characteristics that are happening. And I'll get into that next. Like, I'll get into that very specifically. So how all this connects. So there's 3 domains when it comes to this. One is health informatics, the other is hospital and clinical, and then there's public health informatics. And it's all an interconnected system. When we think of health informatics, I would want you to think about your EHR, your health information portals, your telehealth platforms, being able to kind of, talk to your providers in real time. And from that comes the data, right? So when we think about data, it comes in different formats. So there's a HL7 format, a FHIR format, FHIR, your snowbed CTs, your LOINC codes. I'll get into what each of those mean later. But all of that data then goes into your built surveillance, where you're being able to track and see progression. So, like, say for influenza cases, right? For your regular flu cases, people come into the hospital. The symptom is that they have the flu. That is a HL7 message that then gets translated into a database, right? So that database then gets reported over to the local health departments. The local health departments then would be able to track by zip code or by area, how much of that disease is occurring. So when they see that, okay, like there's a high population or risk of this, then they'll put out the alerts. Then you'll see the news reports saying, hey, there's a lot of flu cases going on in Macomb County or Wayne County. So that's where we get that information from. So with that, with health informatics, we use that information, and then on the hospital clinical side, we configure that data. We make sure that we make clinical decisions based off of that data and provide support. We use that information to help better design our workflows when it comes to hospitals. So each day we're looking, as a hospital administrator, we're looking towards seeing how we can do things better and how we can improve. And then from there, that information then gets signaled on to the patient level. And then how it gets used in public health for the informatics side is to really look at it as a whole population, right? So you're looking at outbreak detections, immunization tracking, and all of your hospital data, your local health departments, your state health departments, your individual lab facilities. All this information that gets sent there gets kind of pulled together and kind of brought together as to one. So that's where we get to see a whole better picture of things that are happening within the community. And those are actually applied within standards. So the electronic disease surveillance system is our NED system. That's from the CDC. It's a nationalized system where we are able to kind of determine and see electronic disease reporting within that. So just kind of a brief history of how we've gotten here. The 1960s, they had these huge big box, computers with, like 3 little lights, and it only had like 1 megabyte of storage, right? That's how, your information systems, started to begin. And then it came to the 1970s to the 1980s when, places like MIT were looking towards building electronic health records, right? They were looking towards seeing what we can, do with this information, what we can build off of in order to, make sure that our information and, everything is, getting to the right place. Then there was a Institute of Medicine report that in 1991, which basically said that electronic health records needs to be a standard going forward. So this is 1991. This is about 35 years before, where they're recommending saying, it would make sense to move towards an electronic health record system. It didn't really get enough traction until like 2004 when the government started a Office of National Coordinator for Health Information and Technology. And that's what really, spurred more interest and more, more of like a national priority of making health information technology seamless and integrated. Now, these are all words. There wasn't enough action until 2009. 2009 is when, when in the midst of, coming back from a recession, in order to have hospitals be able to use and integrate technology more into their work, they established meaningful use incentives. So that is a part of the High Tech Act. And they placed money for hospital systems to be able to implement electronic health record systems across the entire health system. So a lot of these hospitals from 2009 to 2016, even to now, well, even to 2016 actually, really began going towards implementation because they knew that the incentive from the government was going to help create more adoption and more interest in being able to get people to use electronic health record systems. So then that's where you have now, Epic. I don't know if you've heard of the company Epic. That's the major electronic health record company across the world. You have Cerner, which is a part of Oracle now. You have all these other EHR systems which have become household names. But a lot of this was driven by the meaningful use incentive. And then from 2016 to now, we're seeing some rapid growth when it comes to healthcare technology. We're using and applying standards that when I had started on my MPH, it was just a concept at that time. So like to me, the industry is changing rapidly and it's changing daily. And that's where you're learning and you're applying all these new standards and codes. So you have the FHIR APIs. You're going more towards looking at value-based care approaches, which is really trying to how do we incentivize patients to do better, and then how do we incentivize providers to do better. That's what value-based care is really kind of all about. And all of this is really based off of data. So data is what we really feed into really trying to drive improvements.
I have a question.
Yeah, good.
After 2016, like today,
Yeah.
do we have like University student like artificial intelligence in the electronic health record? Like for example, you did your X-ray, then the diagnostic using AI give the doctor like second opinion about this is like cancer. Or do we have something like that?
So there's research being done on that now.
No, in the clinic.
Yeah, no, it can't be live in the clinic yet, because like right now, it's not. Yeah, no, I mean, first off, like it's in research, right? So what we're doing is testing models. We're trying to test the algorithms. We're trying to test the information and ensure that it's correct. And I know that there's instances where it's being applied, but it's not really being used or promoted into daily use. I know.
Do you think like it takes like another 10 years?
Will it take another 10 years? No, I'd say it take probably another 5 years.
Okay.
Yeah, I think we're there. It's just that you need to ensure, and this is where I'm going to get into regulatory standards. Regulatory standards have to apply into how we use AI, into treatment and information. So like there has to be something that regulates how we capture the information and ensure that the information is accurate.
I want to build on that. Public schools get the same funding per pupil, but we're seeing the rural schools are doing a little worse than the urban and the suburban.
Mm-hmm.
How is this going to trickle down to rural?
So you mean?
Everything on your timeline, what was the trickle down process like?
So for
You go to the timeline.
yeah. So for rural, I mean,
That's the trend in schools.
yeah. Oh, what's the trend in schools? I'm sorry.
So there's a new law about something like free and adequate public education. We're going to start taking care of special needs students by putting them in a general ed classroom and having inclusion with all students together. We're never going to pull them out of the classroom.
Mm-hmm.
That was a law. So with the idea in the FAPE law, it wasn't rolled out like you snap your fingers and it happens everywhere.
Okay.
It was very slowly happening.
Okay.
And the rural areas were the last to catch up.
So are you trying to equate this to like how are we applying like health record standards towards rural and the urban areas? Well, it's a great point. I think what we have to look at is truly, funding for these initiatives, right? So that's what it all comes down to, is that there's not enough funding to be able to provide support for rural and urban, health centers. And in fact, within the state of Michigan, they're closing down middle and small size hospitals. So now people are actually trying to, go 2-3 hours for care that they need. And when it comes to our women's hospital, actually, people are coming from across the state, even Marquette. So Marquette's like 6-7 hours away to be able to deliver and see a physician here at Ann Arbor. Yeah. So that's where we're coming towards, is that there has to be enough public support and be able to provide enough funding to be able to cover these hospitals. And unfortunately, they're the last that they're looked at, and it's all about population centers. So now for us as a hospital, we're the last hospital resort. So, and that's fine. That's a badge of honor for us. So we can be able to take care of those patients that need that care immediately. Give me 1 second, sorry. So now, when we kind of think about data, there's several different data standards, and all of these are all interconnected. There's not one thing that on this list here that doesn't understand or speak to each other. So our main focus for EHR data and how the hospital system messages across to different points of public health public health departments, state health departments is HL7. So there's and in fact, if you go on your phone, if you have your phone linked in health to MyChart, which is the patient portal, you'll be able to see your results. All those results are actually HL7 standard, FHIR. And that's why you can be able to kind of pull your records together in your health app to, from, the last time you were seen. So like to me, when the EHR system was, being used or started to be used more, I can see my data from 2014. So, I mean, that is really helpful when we kind of see, progression and pattern. And that is HL7, that is that data standard. That feeds into ICD-10, which is our Universal International Disease Classification. That's what we use for billing and codes. That's what we use to really track and kind of see, new diseases, new, conditions or concerns. And, ICD-10 from ICD-9 is radically different. ICD-10 and ICD-11 now have about probably 100,000 more codes than ICD-9 did. And there's more ways to differentiate and provide, more information. FHIR, which is FHIR, is really more of a application programming interface. Yep. So that's where we're able to take that information that's from HL7 and really kind of be able to kind of show and display that information in a very usable and meaningful format. Your DICOM is your radiology data. So now, I don't know if you ever had an MRI, at some places you can actually see your results right off your phone. You can actually see your MRI right off your phone, and that data standard is DICOM.
For all imaging?
Yeah.
Oh, it's one standard.
Yeah,
Okay.
DICOM, yep. So it's all one standard, and it has to follow that standard in order to be interoperable with other data points.
Don't you compress the resolution?
It's probably all part of DICOM.
Yeah. So there's different standards that have to be applied before the information then gets into a link and then it's available. Your SNOMED, that's your clinical vocabulary, that's terminology that's used within the hospital. Your LOINC is your lab test and visit universal codes. And then you have clinical documentation standard as well, which is CDA. And that is where, we have to have, different formatting, different standards for different documents that have to get, scanned into the media tabs to your electronic health records and being able to be sent out. And then all this is actually governed under a regulatory part, which is HIPAA. And I'm sure that people understand what HIPAA is. It's really to be able to protect our health information. So at any point, if information needs to be shared amongst agencies or places, that information for the general public is usually de-identified. De-identified means that you won't be able to tell who that information is or who that particular person is, but they'll give a demographic and the condition or the location of where it's occurring. So that's where HIPAA and high-tech regulatory standards really have an impact towards all of our data standards here. Yeah.
You were first.
Good.
So the image of MRI or X-ray is available on the my chart
Mm-hmm.
for patient. So what is the workflow behind this? Basically, when the image goes to some database and there's some API
Yes.
calls it
Yes.
and it uploads to the what is the so I mean every hospitals integrate their API or there is some existing applications just need to integrate with it?
Well, there's existing applications from the vendors that kind of integrate with, our EHR system. So, for example, our ultrasound machines are GE, right? We also have a Philips machine, but we have an integration solution that when the images get captured onto those machines, will then feed into the EHR system. When it gets fed into the EHR system, then the providers are able to kind of like review and check out the information, and then be able to kind of send out the link.
Epic is an EHR system?
Yes, Epic's the EHR system. Yep. Yep.
Are all of these open standards? One thing I've had in our field is a lot of the standards are closed.
Yeah. So HL7, I believe, is an open standard. FHIR is an open standard too.
Okay.
Yep.
And the rest seem like they would be open to terminology.
Yes, majority of them are terminology.
EHR is EMR.
Yes, electronic health record, electronic medical record. Yep. So China, kind of in essence, what the data journey is when it comes to data is, it starts off with being captured. So this starts off at your doctor's visits. This is where your diagnoses get placed in, your vitals, your lab orders, and then it kind of moves into a structure. So that structure is that HL7 code, that ICD-10 code, and it kind of gives organization and meaning to, what this data means. So then, when we see a vital of like 147 over 82, okay, that's a blood pressure monitor, and then that data gets structured and then shared into different platforms. So that becomes an HL7 message, and then that interacts with the APIs that really kind of push that data into the labs, to pharmacies, and then our in general our public health systems. And then as administrators, like what we really want to look at is analyzing the data. We want to kind of see what progression or patterns that we're seeing to be able to kind of help operationally. And that's where we have to analyze and identify patterns. So, and that analyze actually varies from different professions too. If I'm a clinician, I want to see, what my patient or my patient population's normal complaints are. If I'm a public health official, I want to see, where we should focus more on their, community-based programs to help with smoking cessation or, things like that. And then from there, we act upon that data. And whatever that action is, it's really based off of that starting point when you capture that initial set of data. So it really takes a pure trip from the initial point of where your information is being captured to actually, policies and procedures and, things being made right. Yep.
So what's being done differently now after COVID? Like, it's another pandemic where it could happen, because there's that hantavirus thing.
Yes, so that's a great point. Hantavirus, that is something new. Right now, like the disease progression is kind of in its infancies. We're not seeing it like COVID-like, but I mean obviously, it's being tracked at a national, at a global and a national level. So once it kind of comes to the States, then that's where we'll begin to be able to kind of track and then see kind of patterns and movements. Like, I actually, let's take hantavirus out of the equation. Let's look at measles.
That's what I was thinking.
Yes. If you look at measles, your date of onset is literally within 7 to 21 days, right? So you're probably infected if you don't have a vaccination for measles. And from there, you then can kind of move around and be able to spread it. And, with measles, it's, highly contagious as well. So then, as a public health official or a public health informaticist, you have to kind of go do your tracking, right? You have to go back to the sources, kind of, get all the locations of where that person might have been, be able to report back to the public of where people have been, and then kind of get kind of be able to have people to be prepared to be like, if you have any symptoms, or you have to you have to come in immediately to be seen. Yep.
Does that contact tracing?
Yeah, contact tracing. Sorry.
Yeah. Does that workflow go through this like HL7
Correct.
fire?
Correct.
Oh, it goes through the same pipeline.
It goes through the same thing.
Oh wow.
And it's very immediate as well.
Are you saying also that if a patient has a disease, because you are surveillance and you know where is this patient in the society?
Well, I think you're looking at where the patient populations are, and let's look at. So Dr. Fauci, right? Yeah. So Dr. Fauci, the reason, huh? What was that? Oh yeah. That's a good example too. She's a great example. When Dr. Fauci was known, and when it came to the CDC MMR report, which is the morbid and mortality report that gets sent out every week to kind of discuss about new prevalences and diseases, it's basically kind of talking about cases that are happening and occurring in groups, right? So when in the 1980s, they were able to kind of see that there were 4 or 5 patients that had contracted a viral pneumonia disease, but they couldn't really understand or classify it. So then they had to study it further, and obviously they understood that this disease is AIDS, and then they had to build treatment plans. So they're able to track at a community level, but at the individual level, yes, like if there is a very known causing disease, they're going to have to be able to kind of see and track that person to be able to ensure that that person doesn't affect others.
So are you saying that the system at UC Michigan is able to track?
No, not University of Michigan. This is the NED system.
The NED system.
Yeah, the NED system is a national electronic disease surveillance system.
Okay, so it's able to track people's.
Like right now where they are live?
Yeah.
No.
And they
No.
ask you, like the patient. I think that's how it works.
Yeah, no, it's not like where their real life location is. There's not like a chip on a person that's going to track their location. No.
They call the phone number and but how they so you said that they track how they
Yes.
track people if there's no chip on them, that's true.
Yeah, so I mean, if they have a contact information, phone number, they're going to track them there.
No,
So they
they'll
can
ask
track
you.
from your phone, right?
No.
They
They
can
go to you
it's-
and ask you, like, where did you go? Where did you go to school? What did you do?
Yeah.
real fast?
So that's all about contact tracing.
But they can track you.
No,
through the
they
phone.
just ask.
No, they can't track you through the phone.
It's like when you have cancer, they have to call you
Yes.
and tell you on voice you have cancer.
Yes. So they have to like contact you, reach you directly. They're not going to see, oh, this person has this phone and they're going to MCWS. Like they can't see it like that. Yeah.
So in the second box you have 3 codes, and in the third box you have 2 codes.
Yeah, so they're different.
It's a set of 3 and 2.
Yeah, so ICD-10 and LOINC are the structures that kind of fall into HL7 messaging. HL7 messaging that carries that to the API. So basically, these are the individual data formats. The HL7 is the data carrier that carries it over to the API solution to be able to display and show that information.
HIPAA sort of stuff happens mostly at this like third box, I'm guessing. Is that where sort of the anonymization?
Yes, anonymization happens around
Like at
step
that
3.
step?
Yep.
Okay.
Yep. So, in essence, what do informaticists really do? It really varies from end to end, and there's new things that are happening every day. But just in general, you build disease surveillance systems. You build the infrastructure that be able to detect outbreaks before they make news. You apply artificial intelligence and natural language processing into health data to be able to kind of extract the information from a physician note that's typed to be able to identify and de-risk populations before outcomes become worse. And then another thing that informaticists do is transform data into decisions. So we take unstructured data, we make it structured, and then from there we build a decision of what we should do and what is our outcomes. We also build clinical decision support systems. So if looking at our best practice advisories of things that physicians or clinicians need to do, we build out order sets to be able to help providers quickly put in orders for patients. We design alerts to be able to kind of show if there's a medication error, to be able to alert the physician or alert the nurse saying that this drug may interact with this, do not give this. And that's what really kind of helps build our systems. And then the two things that I really enjoy the most is really being able to use interoperability, being able to connect systems together to be able to kind of understand each other, talk, and really understand where workflows and data works, and then being able to train and drive technology adoption. This is key. This is really key because you have providers, you have clinicians that have been in the field for years. This is all new, and it's really being able to help them to be able to build their to make it easy to use, and that that there isn't really a complication towards this. Yep.
So, in terms of the system that support being informatic, is it like built-in system or something that is customizable?
Yeah. So it's you have your out-of-the-box solutions, and then you have your customized solutions. So it's honestly a new world when it comes to what we could do to make and drive decisions to be better for healthcare.
Can you give us some examples? Like what type of
So, and I was going to get some examples at the end. I have like a list of what we're doing. Yep.
So the change management and training. So like medical staff or doctors, they use applications from years. So that technology adoption is a really big challenge for
Yes.
training.
Yes. Technology adoption is a huge challenge.
So how you guys train them and how?
Well, I mean, we have to separate time, right? We have to work on the physician schedule. We have to work on the nurse's schedule. Nurses, in most cases, are unionized, so we have to work with the unions to be able to saying, hey, we have a new technology coming out. This is probably going to take about 6 weeks to train on. We need to get these people trained. And then that's where they run into questions, and then that's where we have to accommodate to be able to build that training. So it's really a iterative process. It's never something that it's one and done. You're always continuing to learn, and you're always continuing to drive.
Not to be Debbie Downer, but I have kids at third grade reading level. I
Okay.
can't even tell you what class level I expect them to be. So how do you enforce the training? You've given someone 6-week training. You check on them next year and next year.
Yeah. So I mean, what we've built out is our educational learnings, our checklists, being able to provide documentation or be able to on-demand tip sheets, things like that to help providers be able to use the system as they're as they're working.
Provided the training and the material. Imagine the student that doesn't turn in their homework.
Uh-huh.
And that happens every day as we speak.
Yeah.
So what happens when the hospital staff are not following the training and they've had like
Then I mean,
the yellow card, the red card thing?
yeah, then, obviously we have, a system in place where if they're not getting the training, then they're going to need to be, remediated and, help be trained up further. If they're still not getting it, then we go through our whole disciplinary process. That's like a performance improvement plan. So that's what we kind of go towards.
So just one last question. Like, do you need to know everything? It seems like a lot to me, having the building API and training them.
I think
Does everybody need to know, or you have like certain people like focus on certain?
I mean, I think it's good to know how these things interconnect. You can be perfect at one thing, but I think one thing that kind of escapes people that work primarily in tech is that they don't understand the business side of it. They don't understand. They can't translate technology to business or in operations. So really, like, if you're able to understand how these things connect, then it will be successful on the business side when it comes to translating that to the tech side. So that's where this comes in. And then our technology stack that we usually use within informatics, our EHR systems are your standard Epic, your Oracle, Allscripts. Your disease surveillance systems are your NED system, which is the National Electronic Disease Surveillance System. Your immunization registries, your natural language processing machine learning systems, or your nuanced DAX or your co-pilots, your sepsis. Yes. So DAX and Copilot is really helping providers a lot.
Wow. It's
Yes, it's all Microsoft based. And then our GRC compliance solutions like MetricStream, to help with auditing and our policy management systems. We use Tableau, Power BI quite a lot. Epic has a system called Cogito or Slicer Dicer, which we're able to, capture data and be able to cut through data in real time. Obviously, we use SQL, Python, R, and I want to say with SQL, Python, and R, no, not R, but SQL and Python, it's great that you can check your code against ChatGPT to kind of confirm and see if that code is going to work. Because for me, for years, SQL was a barrier. And that's why I was just like, I'm going to deal with project implementation. Oh, cloud-based system? Yes. So we are all cloud-based. Like our
cloud or Claude?
Claude. Oh, Claude.
Cloud.
Oh yeah. So we are cloud-based system. Yep.
What company do you
We use Microsoft. Yep. And then our clinical decision support systems.
When did you stop using Excel in that stack?
Well, Excel is kind of like a thing that we're going to continue to use. So to me, yeah, that's
like English.
that's it's used for everything. It's used for scheduling. It's used for everything. So that's why it's not a part of that. Cloud?
Yeah, Claude.
Claude, yes, I use Claude. I actually started trying Claude a few months back. I enjoy it.
How does that work with HIPAA though? Like, is that a
It's a challenge. But I will say for like business requirements documents, oh my gosh, it's beautiful.
Yeah, me too.
Oh, because when I used to make business requirements documents, like it would take months, right? You had your template and then you had to build out the document. Now I can just come up with an idea and then build it. That's why I love it.
Can Copilot do what Claude doesn't?
Yeah, so it depends on what instance of Copilot you have. I think the safest thing is to not use like HIPAA, type of data or markers within the AI system. Like I would use it to, be able to play off a scenario, to build out, requirements documents, but I would never use it with patient information.
Last question. University of Michigan was really quick to do Maisie, which is a version.
Yes, Maisie ChatGPT. Yep.
Does it fit here?
So technically, What we've understood from campus is yes, is that you can use ChatGPT with HIPAA. Would I trust it? No.
What part of this is Maisie?
I didn't add Maisie because I don't think people are going to understand what Maisie is, right?
Yeah.
People are going to understand what ChatGPT is. That's a part of AI. But, I think there's other health solutions outside of ChatGPT, Claude, and whatever have you that actually do work and that we actually end up using in the hospital space. So DAX Copilot is really helping our providers. As a health informaticist, you're really connected to everybody. You're connected with your patients and communities. You're really taking in that information from them. You're working with your nurses and allied health partners, allied health being your respiratory techs, your sonographers, your other clinical leaders that actually, do patient care on a daily basis. And then you're working with your physicians, clinicians, to really kind of help them understand what they can do with the data and what decisions do they need to make. You're obviously connecting with IT a lot, so you're working with your individual IT, EHR teams to be able to help build the system be better, to help take the information that's from the provider to be able to build out to what we would want to see in the system. Obviously, we work with people in the CDC or public health departments, the CMS, which is the Centers for Medicare and Medicaid, and your executive and C-suite level people as well. So why does all this matter? Really, when we think about healthcare, when we think about data, it's applied to the most human problem there is. So everything that we build, every system that we build, every standard that we implement, every data pipeline we design has a direct and measurable impact on human life. So really, the stakes are real. If we have poorly designed systems, we will have poorly designed alerts. We will not be able to help people in the time that they need it. We can't detect what the eyes can't see. So epidemiologists, for example, can't monitor 10 million patients, but informatics systems can be able to kind of take that information and be able to help track and provide that population data that would be invisible to us on a normal day. Where we think that AI is being deployed. So when we think AI with sepsis prediction, sepsis is a serious infection, right? When people have sepsis, the risk of dying, it immensely increases if it's not caught or treated in a few hours. So prediction for that is, with AI is really helpful, and we're able to beat sepsis in some cases. Your imaging diagnosis, so you can, there's apps now, and there's data where you can diagnose diabetic retinopathy through a quick picture off your iPhone, and they actually will detect diabetic retinopathy. And then your ambient clinical documentation, so that's where DAX Copilot comes in, and I'll talk about that next. You work across everything, so you work towards configuring the EHR system. You can brief the chief medical officer on that. You can debug HL7 feeds. You can design surveillance reports. You can train 300 nurses. You can do a lot with being just being an informaticist. And health equity. So one thing that we have to think about within healthcare is ensuring that everybody is treated equally, that we determine then who gets flagged, who needs that intervention, and who needs that access towards that care. So we're not falling short of trying to treat everyone. So we want to make sure that we treat people on a timely basis, and that's where health equity matters. And then we're the bridge for this. So then physicians speak medicine, engineers speak code, epidemiologists speak statistics, but informaticists speak all three. So you have to be able to understand where everybody's coming from in order to help design and develop and build solutions.
So question on the AI, is agentic AI coming into the play?
Yes, agentic AI is coming into play, and that's where I'm going to next. Here we go. So where are we headed now? So generative AI and ambient documentation. So this is where the DAX Copilot implementation, where we're really taking clinical notes. So what it is that you have your phone app being plugged in at the same time, and you're going ahead and you're asking, you're documenting, you're having the patient be able to kind of talk about their concerns, and everything is being transcribed and captured into this DAC Copilot system. And so it's easing on physician documentation. It's actually relieving physician documentation quite a bit, and that's where we're able to kind of see a lot of improvements when it comes to that. So not having a physician on the keyboard and being able to have them see other conditions or be able to do research is a huge thing for us. So we really want, are focusing and building up more of our ambient documentation. Yeah.
The LLM, are those like trained?
What was that?
Those LLM trained specifically for this, or you use like?
Yeah, so it's actually an app off your phone, and then once it integrates into Epic, and then as you're seeing the patient, then it kind of builds in that clinical note and record.
My question, are those like based on the currently available LLMs, or those are like trained specifically for?
Yes, so it's based off of the language models. Yep. Precision medicine and genomics within the EHR. So within this, we're using AI to kind of help build genomic risk scores. We can build out targeted therapies for people. We can, understand better, disease identification and, what's inherited and what's not. So that's what's coming up in the future. Our social determinants of health. So what social determinants of health focuses on is, not just the patient, as they're being seen by the provider, but what are other factors that are affecting the patient? So it's housing, food insecurity, transportation, things that, aren't normally asked for, we're being able to kind of capture and track within our EHR system to be able to help provide better solutions. So that's, connecting them to social work or connecting them to other resources within the community to be able to be, and to be able to provide what they need. And
do you feel like there is a pushback from the clinician because they feel they will get replaced by AI, like for the precision medicine?
I'll be honest with you. I don't think a physician could be replaced by AI. I think AI is assistive.
No, they feel. Like
What do they feel?
Yeah.
No, I think, to be honest with you, I think every physician is completely burnt out.
Oh,
Every yes.
Yeah.
So every physician is completely burnt out.
Because-
COVID.
Because the face time with the patient is getting shorter.
Of course, because we have to see more with less, right? So anything that can help assist with diagnosing and helping with their workflow, they're going to welcome it. So that's why I don't think AI is going to replace a physician at all. I think it's going to be very assistive. There's probably going to be some countries that are going to try and say, oh, there's an AI physician. China's probably going to be the first one, right? China's going to, have an AI physician, and unfortunately, it's going to diagnose a person that has Crohn's disease with,
Hospital full robotics only.
Yeah. So it's all robotics. But the thing is that there's actually a physician behind the scenes that has to verify.
Yeah, but if they teach the robotic, like they get to the AI and learn it enough, they're gonna know how.
Yeah, but I mean, who's going to pay for the treatment? Or how are things going to get paid?
People doesn't trust
Yeah,
it.
that's why it's not going to get trusted.
In the genomics part, the Verka gene kind of unlocked the map. Is that the trendsetter for breast cancer, or is there another disease or specialty that's benefiting most?
I'll be honest with you. I'd have to get you a very particular example. I can't think of one off the top of my head right now, but I just know from reading there's a lot of things happening on in the genomic space. I just can't tell you which.
I'm just curious if it's
Yeah.
hematology or
I'd say oncology, to be honest with you. Yeah. And then true interoperability, which is near, it's probably about 5-10 years away, but being able to have all systems be able to speak with each other, I think that's what we would try to achieve and hope for. Yep.
Why won't Epic or Oracle allow this? I mean, this is something we've seen in my industry, like in the auto industry, a lot. Like the sort of
I think they would allow it because it's healthcare, right? It's at the end of the day, it's about the patient. It's about ensuring that the patient has their information available with them, and that if they go from one hospital to another hospital. So say if I'm a patient here at Michigan Medicine, but I go visit in Florida, I get sick. Will my information travel with me, or what do I have to provide? So that so in that case, you have to have that information be able to be available and readily available, and be able to have systems to be able to talk with each other, regardless of how functionality may different from from CERN or from Oracle to Epic.
have these companies, in your experience so far, been okay in terms of being good stewards?
I think they have to be, right? So like essentially, when it comes to Oracle versus Epic, it's about user functionality,
Okay.
right? And that's the only difference, but because all the information is going to be the same.
Okay.
So the difference is really on usability and functionality.
That's awesome.
I'm curious. Students get a student number when they start from kindergarten, and
Mhm.
it follows them to every school up to 12th grade, and that's called a CA60. It just goes with
Yes.
you. Is there a number, like a social security number, that goes with you everywhere?
Not yet. I mean, for healthcare?
Yeah.
Yeah, not yet.
Oh.
That's something that I know that I think the UAE, Qatar has also done with their national health like registry.
The national number.
Yeah. So that's, I mean, to me, ideally, do I see that happening with us? Would that be great if we can use our social security numbers, as we go elsewhere? Yes. Do I think the general public would understand? No. And would they understand the value and the benefit of that? I don't think they would. And because I think people have really treated misinformation, to the upteenth degree. And to me, I think when it comes to a nationalized type of number, I think something like that would be helpful and useful for the,
For health.
yeah, for healthcare. But unfortunately, others don't see it that way. So.
So if I go to two hospitals,
Mhm.
Michigan and IHE,
Yes.
and I have my chart in each one of them,
Yes. So
my information will be pulled from both of them goes to here.
yes. So no. So it'd be able to be seen by each other hospitals because they're both on Epic.
If
Only
I decide to
because
do that.
Yeah. No. No.
If I link them.
Yes. And also, there's something called Care Everywhere. It's a part of the health. It's a health information registry called Care Everywhere, and that's where all the information as you're being seen in your visits would be kind of captured and recorded as available if you go to a non-Epic site. So if they go to a place that uses Oracle, then if they go into Care Everywhere or Care Anywhere, they'll be able to pull that record from your last hospital.
Okay, so if I go to another hospital that doesn't use my chart,
Yeah.
all of that data is still pushed to the Care Everywhere.
Yes, correct.
So that my chart doctor from another hospital will be able to see from Care Everywhere where I'm coming, where.
Yep.
Okay. So my question is that when I went to my chart in Michigan, I have to link my chart in IHA.
Yes.
So the doctor in Youth Michigan can see that. But even if I didn't link it, he can still see
Yes, he can still be able to pull it. Yeah.
without even if I didn't link it.
No. So if you
That's
No,
making an entry.
no. So if you are able to provide like approval for it, no. If you're able to provide approval for it, then he's able to see it.
Say it again. I'm sorry.
If you're able to provide approval for it, then he's able to see it.
How can I able to provide what is it? How does that function? Do I have to sign it or when I?
Yeah, so when you're building your portal, it's going to ask you do you want your information to be shared to your provider? And if you mark yes, then it will share that information to your provider.
Okay, but what I recall is that I go from the admin side and I go and I link all of the hospitals that I want them to be linked together so
Yeah.
they can see the data. But I can also go and unlink it.
Yeah. So then when you unlink it, then that information wouldn't be shared then.
But based on what you said, that they can go to health everywhere. What you
Yeah. So that's what it does. It basically it shares it based off of what you select as the user, right? So if you say that I want my provider to see my information, then when you select yes, well, where's your provider? It's at this location. Then they're able to pull that information. If you don't provide that information, then it won't be able to pull. It'll be an individual record at that hospital.
So even the health everywhere, even if they are not using my chart, they will not be able to see other providers
Correct.
that are not using my chart.
Unless if you agree to it. Yeah. All right.
So when you come here for the virtual patient, for predictive simulation for in the future, for the virtual patient models. So this model for the patient, who will create this model for the patient?
I think it's based off of data and scenarios that we see at the hospital, and then from there you're able to kind of predict based off scenarios of what could occur, and then how we would be able to treat. So that's how we would use predictive simulation. So it's not using actual patient, it's actually using and then agentic AI in public health. So it's really having a system that continuously monitors disease signals and help be able to kind of coordinate response. So I think when we think of the COVID pandemic, if there was a disease registry that was kind of linked into agentic AI, it would help with the text messages that you would get. It would be all automated versus a person having to reach out and contact trace. So it would help with contact tracing immensely. So that's where I see agentic AI really helping in public health, especially with contact tracing.
So you see it as future, still not done yet.
No. I think they're building. Like there's a lot of things that have to work in order for this to be used all around. And with that, any questions?
One basic question. So, the traditional healthcare tech, the basic difference between traditional healthcare tech software or company and health informatics.
So you're talking about like the health information. So healthcare technology companies like the ones that build your devices, your healthcare detect devices, or
The healthcare software, they build healthcare software.
like EHR systems.
Yeah, something like that. And
Okay.
So in health informatics, so basically software development is not involved there. It's more workflows and
Yes.
analyze the data and
Yes. So basically, what we do is we take the technology and we look towards seeing how we can apply it towards bettering our workflows within the hospital.
You don't have to have a skill like a language skill for software or something like that.
No, I mean, I think I'll be honest with you. Like, if you can understand SQL and Python, to be able to help with reporting, that should be fine. You can also do the same thing through AI now, and that's much easier. So, yeah.
I'll take one more question.
Yeah.
Brother Adnan, that's great presentation. Do you have a contact email so we can?
Yeah, sure. I don't know if I have my business card, but yeah, I can actually send out my LinkedIn, inshallah. I can send out my LinkedIn.
We'll pray Isha. Jazakallah khair, brother. And then, honestly, this was probably the best slide deck we've ever had, and one of the most informative presentations. Thank you so much for dealing with the delays as well. Barakallah feek. The recording, yeah, give me a sec.